All right, everyone. Thank you for joining us today. We're going to go ahead and get started. This is the first session of the third series of perinatal focused mental health tele-echo for PPCL. I'm Jody West. I am the coordinator of the ECHO and the program manager for the provider-to-provider consultation line. I want to introduce a few other folks on our team. I want to welcome everyone and thank you for joining us. And here is the agenda that we have. We're going to do our best to stick to it because it is a pretty tight timeline. We'll start with introductions of the hub team, which is our group of experts in different areas of practice. And then we'll move on to the didactic presentation. We do not have a case presentation today, so we need y'all to think about any cases you may have that you want to bring to this group. That you may have some questions about, because we do have a psychiatrist available, we have psychiatric nurse practitioners, we have social workers. So please take advantage of the time and expertise of the panel that we have. And then we'll go through some clarifying questions, recommendations, and some announcements. Like I said, I'm going to introduce myself first before handing it over to Dr. Finelli, who is our facilitator for this series. But I'm Jody West, like I said, a social worker with the provider-to-provider consultation line. We provide trainings for non-mental health and mental health providers focused on mental health. And this one happens to be for perinatal mental health. We do another one for pediatrics, which is on another day of the week. But you can also contact us through our phone number or our online consultation form if you want to talk and consult with our team about a patient or client that you have and their mental health needs. We can connect you to a psychiatrist if there are diagnosis or medication questions. We can also help with resources and referrals in the community, and we provide that information back to you, and then you provide that to your patient or client. So I'm going to go ahead and hand it over to Dr. Finelli. I'm going to leave the PPCL slide up in case anyone wants to scan that and get more information and get signed up for our newsletter. But I'm going to turn it over to Dr. Juliana Finelli, who is going to introduce herself and then the rest of the hub team.
Thank you, Jody, and thanks all for joining. My name is Juliana Finelli. I'm a child psychiatrist and a general psychiatrist at Tulane, and my focus is perinatal psychiatry and infant and early childhood psychiatry. And I serve as the facilitator for this ECHO project, and also work with PPCL as one of the perinatal psychiatry consultants. So I'm going to pass it over to Dr. Zena to introduce herself.
Hey, everybody. Welcome to this new year. My name is Paula Zena. I'm a clinical psychologist and also pediatric nurse for many years. I serve on the hub team as kind of the nursing consultant, but also psychology consultant. And this is always a fun, pleasurable experience. I hope you enjoy it today.
Thank you, Dr. Zena. I'll pass it over to Katie Abear.
Hey, y'all, I'm Katie Abear. Good to be back. I'm an LCSW and also perinatal certified. And I'm located in Lafayette, Louisiana, and I work at Bloom Mental Wellness in a private practice setting.
Thank you, Katie. And Lena Raggett.
Thanks, Dr. Finelli. Hi, everyone. My name is Lena. I'm one of the social workers on the team. I'm also one of the mental health specialists for PPCL. So I do a lot of behind the scenes IT work for the hub team and for the ECHO, but it's good to see familiar faces and new faces on the call. Looking forward to the series this year.
Thank you, Lena. And I think before we begin our didactic portion, Lena was actually going to tell us a little bit about PPCL. Anything to add, Lena?
Yeah, no, just to reiterate what Jody mentioned before, we do have a consultation line open Monday to Friday, 8 to 4:30, where folks can access us for resources for their patients or clients and have the opportunity to speak with our perinatal psychiatrist. We also have a child and adolescent psychiatrist on contract with us, as well as an OBGYN/addiction medicine specialist. So if there are concerns about mental health and or substance use disorder within those populations, we're here to help and support. Oh, before I forget, I'm also going to drop an interest link for some training opportunities that we have through PPCL. So if folks are interested, please check that out and feel free to fill out the interest form.
Thank you, Lena. So I guess we could go ahead and get started with the didactic presentation. So I'm going to do my best to keep on time. So we have sort of a short amount of time today. We're talking about bipolar disorder in the perinatal period. Of course, that's a big topic, and we have about 15-20 minutes. So we won't be able to cover everything. I'm really going to just touch on some core principles, and then hopefully there'll be questions or maybe even some case discussions related to this. So we could move forward in the slides, please. So our objectives, we're going to first talk about risk in the perinatal period, the risks associated with bipolar disorder, particularly risk for relapse for pregnant patients who discontinue their medications. We'll talk, again, some very basic pharmacologic and non-pharmacologic principles when it comes to management for patients with bipolar disorder during this period. And we will touch on some safety considerations, including briefly postpartum psychosis. Next slide, please. So first, I just wanted to touch a little about bipolar disorder diagnosis. We have a variety of different professionals who join us. And so I know we have a lot of mental health professionals for whom this is very familiar and maybe a very active part of your practice. But it's just important to touch on this briefly before we talk about pregnancy. Of course, bipolar disorder is a chronic and complex mood disorder. It really is complex, characterized by episodes of mania or hypomania and depression. And the key there is the word episode. It's the episodic nature of bipolar disorder. And that's where a diagnosis can be a little bit tricky in understanding how to diagnose bipolar disorder. There is some data that suggests that bipolar disorder is frequently misdiagnosed in primary care settings. And that goes in both directions. So clinicians, physicians and other clinicians diagnosing bipolar disorder when it's not actually present, and then also failing to diagnose bipolar disorder. And that particular happens for patients who have primarily depressive episodes, and then those kinds of episodes of hypomania or even mania might be missed. Really, diagnosis of bipolar disorder, it does require a comprehensive clinical assessment. And that assessment involves taking a careful longitudinal history, generally involves getting collateral information, whether from other providers or very often from family members. And it involves ruling out other diagnoses, including substance use and substance-induced mood episodes, a lot of trauma, PTSD, and just subclinical PTSD, trauma-related, hyperarousal trauma-related, mood dysregulation, and also personality disorders and personality pathology. As everyone knows, in the DSM, we have a number of different diagnoses under that umbrella of bipolar spectrum disorders. And it matters because it really impacts our treatment decisions. It impacts prognosis. The difference between bipolar 1 disorder and bipolar 2 disorder is important from a treatment standpoint. Cyclothymic disorder, other specified sort of bipolar spectrum disorders, so patients who don't meet full clinical criteria for other disorders. And the core specifiers really matter. Core specifiers matter throughout the DSM, and they're relevant for many psychiatric diagnoses, but they're particularly relevant for bipolar disorder. And if anyone's looked at the DSM recently, paged through it, there's a lot of details, and it's not just the DSM being extra. It really matters. It's a very complex disorder. And so understanding current polarity, so most recent episode depressed, most recent episode mixed, most recent episode manic, peripartum onset, that specifier is important, and we'll talk about why. Patients with rapid cycling, patients with mixed features, psychotic features, all of those specifiers matter greatly when it comes to determining treatment, including medications, but also prognosis, treatment course, and how we're going to manage. Next slide, please. So why are we talking about bipolar disorder in pregnancy? Well, a number of reasons, but one is there's something about the perinatal period and bipolar disorder. We don't fully understand it, but what we do know is that looking at the data, the perinatal period actually carries the highest lifetime risk for first onset of bipolar disorder. So what that means is patients who are presenting with their first mood episode during the perinatal period have a higher overall risk of having an underlying bipolar disorder. So this was a study from 2015 that found that Of patients who just screen positive on the EPDS, that's the Edinburgh Postnatal Depression Scale. It's a screen for depression in the perinatal period. Almost 20, over 21% of those patients also screen positive on the mood disorder questionnaire. That's a screen for lifetime history of bipolar disorder. And similarly, Catherine Wisner and colleagues in 2013 found that almost 23% of patients who had a positive EPDS score ended up being diagnosed with bipolar disorder. So not just screening positive, but actually getting a diagnosis of bipolar disorder. And that is a higher percentage than you would expect in the general population. So there's something about the perinatal period. It's also relevant when it comes to pregnancy because the treatment for bipolar disorder is different, as we know, than it is for unipolar depression, for example. And when we're making treatment decisions in pregnancy, that's particularly relevant. We want to make sure that we know our diagnosis and what we're treating, and we're treating it with the right medication or interventions. We also know that pregnant patients with bipolar disorder, they have high rates of recurrence, particularly when they are not taking or they discontinue their mood stabilizers. So this graph that I'm sharing, this is from a 2007 study. The purple is patients with bipolar disorder who maintained their treatment, and the orange is patients who discontinued their treatment. And we're looking at time following conception and period without recurrence. So really high risk for recurrence for patients who stop their medications. And then we also know that patients with bipolar disorder are at increased risk for postpartum psychosis, which fortunately remains a rare occurrence, but it's important for us to understand that risk. Next slide, please. So because of all this information that we know about bipolar disorder in the perinatal period, the American College of Obstetricians and Gynecologists, in their most recently updated guidelines, they make suggestions, they make recommendations. Recommendation is considered a stronger suggestion. So they suggest that everyone receiving perinatal care be screened for bipolar disorder. And they recommend, so a stronger guidance about recommending screening for bipolar disorder before initiating any kind of pharmacotherapy for anxiety or depression. And I've just shared a couple, the mood disorder questionnaire and then the city bipolar screen, which we're happy to share if folks are interested. Next slide, please. So briefly, I want to touch on postpartum psychosis. It's, again, remains rare, 1 to 2 per 1,000 births. But when it occurs, it's associated with really high risks. It's high association with significant mortality. So postpartum psychosis occurs in that first month postpartum, and it can occur rapidly. So in that, even while patients are still on the labor and delivery floor, can have onset. So it's pretty rapid in onset. It can be very patients can progress very quickly. There's a strong link to bipolar disorder. And in fact, it's such a strong link that when a patient has postpartum psychosis, we assume that patient has bipolar disorder until proven otherwise. So there are some rare cases of patients who only ever have those symptoms around pregnancy, but we assume, because that link is so strong, that the patient has underlying bipolar disorder. It's characterized by really significant and can be really rapid mood swings. It can even have some confusion and has can have a delirium-like picture, patients with waxing and waning in their mental status, agitation, delusional thoughts, often related to the baby, paranoia. There may be hallucinations, including visual hallucinations, and patients may experience suicidal or homicidal thinking and behavior. It's considered a medical emergency and almost always requires hospitalization, always requires medications. Increasingly, the mainstay of treatment is lithium, plus or minus an antipsychotic, which again points to that strong link with bipolar disorder. Next slide, please. Thank you. So again, just to briefly mention, ACOG also has guidelines about postpartum psychosis identification and treatment, and also about assessment for safety for patients who screen positive on that self-harm question on the EPDS or the PHQ-9. Next slide, please. So this is a common question we have. We might have OBGYNs or family physicians call and say, I have a patient, she's pregnant, and she tells me that she has a history of bipolar disorder. I don't know where it's coming from. She's not sure who diagnosed her. I don't know what to do with this information. So when it comes to bipolar disorder, the history is really important. And we're often helping kind of to walk through OBGYNs and family physicians and getting this history, or as much of it as we can. So when was the patient diagnosed? Have they been treated with medications? If so, which medications? Were the medications helpful? How long did they take them? What did they help with? Has the patient ever been hospitalized? And that's not to say that patients who don't have a history of hospitalization are not at risk, but that just adds to the way we think about risk and the way we make decisions about treatment. So were they hospitalized? Why? The length of the stay tells us a little bit about how long it might have taken that patient to get stable, what kind of treatment they received, and always, always any history of suicidal ideation or suicidal behavior or self-harm behavior. All goes into those risk considerations. Next slide, please. And then I just want to touch on this too, the importance of collateral information. Collateral information is helpful for many of our patients when we're conducting psychiatric assessments. Depending on the patient's age, it might be even more critical. But with bipolar disorder, it's particularly important because one feature of, for example, a manic episode is lack of insight. And if you've looked at the DSM criteria recently for mania, you've probably noticed some of those criteria have to do with what other people observe of us, including for hypomania as well. So as for hypomania, it's one of the criterion is it enough for other people to notice that different baseline? Patients don't always have that insight. So it's particularly important to get collateral. We always get it with patient permission, but it's really, really important and helpful for us. So obtaining medical records, speaking with current or past psychiatric care providers, and then getting that patient's permission to speak with a trusted family member or friend, someone who knows them well. And I'll add here, usually that conversation is mostly one way. I'm hearing from that person rather than sharing information about the patient. I still get permission, but really that's what I'm looking for, is just to get some collateral from somebody who has observed that patient over time. Next slide, please. So this is, everyone who's come to this is probably bored of this, but whenever we talk about treatment decisions, this is always what we're starting with, which is reminding ourselves that there's no risk option. And that includes for patients with bipolar disorder, certainly. So it's not like we're comparing risk to the fetus associated with a medication exposure versus no risk. It's two risks. Risk to the fetus associated with exposure to a medication in utero versus the risk to the fetus associated with exposure to untreated maternal illness. And generally, in most cases, that risk kind of weighing is in favor of continuing a treatment that's working well. Next slide, please. So I want to add this here. Usually when we get calls, the patient's already pregnant, and that's fine. That's what we're here for. We help with that. But it's probably something we should be thinking about more, certainly as mental health clinicians and as psychiatrists, people prescribing medications. We should be talking a little bit about like preconception planning. So any of our patients who have the capacity to become pregnant at any point in their lives, we really should be asking these questions. Are you actively trying to get pregnant? Are you actively trying not to get pregnant? Are you open to pregnancy? And based on the patient's response, we can guide them. We can provide some anticipatory guidance. Even if this is 5 years down the line and they do get pregnant, we want to give them some guidance about what to do if that happens. Pregnancy is not the best time to be experimenting with medications. And so really, ideally, we're starting these discussions before the patient is pregnant. Next slide, please. So just to talk a little bit about research limitations very briefly. Because of longstanding kind of issues with how we conduct research and how we classify pregnant people when it comes to research, we are really lacking in high quality data, that highest quality data, which is randomized controlled trials or systematic reviews and meta-analyses of randomized controlled trials. So we're often forced to rely on observational studies. That means we're looking at pregnant women who choose to continue their medications in pregnancy versus pregnant women who choose to discontinue them. And the problem is those two groups aren't equal. There's an inherent bias there, and it's very difficult often to control for the underlying illness when we look at outcomes. There's also shared genetics between mother and child when we look at outcomes. The bottom line is that no single study tells the whole story. We can't just look up one study and say, oh, here we go. We have to look at the accumulated data over time because overall the data we have is less high quality. Also, just a note, we don't have time to get into it today. Relative risk is not the same as absolute risk. So a lot of studies you might look at some might find an increase in relative risk for a certain outcome associated with a medication exposure, but that means nothing unless we know the background risk. And in many cases, a study might find an increase in relative risk, but the absolute risk remains low. Next slide, please. And I'm flying through this. I just want to note too, just to remind folks, because this is often a surprise to people, those FDA pregnancy categories, category C, category B, category X, those don't exist anymore. They were actually done away with. discontinued because they were kind of overly simplistic. They were falsely interpreted as being a grading scale, which they are not. Those don't exist anymore. And so we could talk more about like what the FDA now does. But the bottom line is there's been a lot of progress over time in how we understand risk in pregnancy and medications. Next slide, please. So the key principles, we won't get into medications today because we don't have the time, but our key principles, particularly in bipolar disorder, avoid abrupt discontinuation of psychiatric medications during pregnancy and breastfeeding. When providers call us, we remind them, you have time. We don't have to make a decision right here, right now. The fetus has already been exposed, typically, when a patient's pregnant and on a medication. We have time. Please don't abruptly discontinue medications. And we tell our patients that too. There's significant risk associated with that. Generally, we use the treatments that worked well in the past. A treatment that worked well before is likely to work well again, and that limits the overall exposures to the fetus because we're making a best chance of limiting exposure to untreated mental illness. We prefer monotherapy at a higher dose versus adding more medications. Sometimes we need to add other medications. And we always talk about using the lowest effective dose, not the lowest dose. We want to treat to remission just like we would outside of pregnancy. When it comes to choosing a medication, honestly, history of effectiveness is number one. It's actually the first consideration. We consider prior exposure during pregnancy to limit overall exposures, and then we consider available reproductive safety data. Always thinking about non-pharmacologic interventions, therapy for everyone, social supports, dyadic interventions for patients who are, whether they're postpartum or they're pregnant, we can consider dyadic interventions. And then, as I mentioned, preconception counseling. Next slide, please. So I want to mention a little bit more about non-pharmacologic interventions for patients with bipolar disorder. I mentioned in history gathering, it's so important to have collateral. Also, having family members involved in treatment. So planning ahead with family members involved. What are the signs that we might need to make a change with your medication? What are the signs for which your partner should call your psychiatrist? Right? And let's have an agreement ahead of time about how they're supposed to call, when they should call. Sleep hygiene is huge for all patients in the perinatal period, including patients with depression, anxiety. It's particularly important with bipolar disorder because of the risk of recurrence of mood episodes with sleep disruption. So really our goal is 4 to 6 hours of uninterrupted sleep. And if you are exclusively breastfeeding on demand, that's really almost impossible. So in involving other family members, partners, getting help with those nighttime feedings, and even the decision about whether to breastfeed, it's less about medication exposure in breast milk. It's more about breastfeeding and its impact on sleep for the caregiver. So really that decision should be considered very carefully. I added here just a reminder of the dramatic hormonal changes that occur during pregnancy, following delivery, and also with weaning, another potentially high-risk time. So all of this requires careful monitoring for patients with bipolar disorder. Therapy, and again, self-care, exercise, engagement, and social supports. Next slide. I know I'm probably coming up on time. And then just to share, and we're happy to share these in the chat, or I can share them however, some resources for shared decision-making with patients and families about treatment decisions. And the last one there is to call us, like that's why we're here. So I hope this was helpful, but we're also here to answer questions about your patients, when those questions arise. And I think we might have a little time for questions because I don't believe we have a case today. So I just wanted to see if there's any questions from our participants.
Juliana, it wasn't actually